miss anyone. And I'll turn it over now to Scott and Manisha to give you an overview of the agenda and our objectives.
Thanks. I'll kind of start this and try and keep it brief so we can get into the meat of the meeting today. So the goals for this work group, I think, are still hold. They're the two items at the top here, and these are, I believe, born out of kind of the long-standing effort of a lot of the folks from this group to have a better, sort of more holistic understanding of behavioral health system and outcomes for folks who are involved in that system by leveraging different resources that the state or the participating agencies have available to them. So we're trying to make it so that the members of this group can get data that they want or need for their work, and hopefully that's the goals here enabling us to implement that in some fashion. Today, I think we're taking I guess you can see the rest of the agenda here, taking a deeper dive into the dashboard project, which Elise will kick off in a second, which is something I think has come up in previous meetings, but we haven't, I think, focused as much attention on it. So we'll take a little closer look at that, and then in the remaining time, go through the effort to look at data, integrate the options to integrate data across agencies for behavioral health, and look at the potential design for that, ways we could do that. And again, that would be of practical use to the members of this group. Did I miss anything? Or at least so.
Perfect. Nothing for me to add.
Okay.
Excited for the discussion.
Sorry.
Thank you. Thanks, Scott. I'll go ahead and share the PowerPoint. So we last checked in on kind of a set of indicators that the work group had agreed on based on a framework from the prior iteration of this work group. And a few weeks ago, I, based on our June work group meeting, I sent just an initial look at, the specific sources, their availability, ability to disaggregate the data, and sent that spreadsheet out. And again, it was just an initial take on it, a lot more to do, obviously. But we wanted to really check in today and get your thoughts after kind of seeing that information. And I also have it summarized on this in the slides if that's of interest for the group to go through. But we have kind of some broad questions that we thought could help us form some next steps and some further direction around the system dashboard. And really, ideally, I think what we would like to do is get to a point today where we can get some direction that allows maybe a mock to be brought back to the group for the next meeting of some indicators of priority, or some indicators that are maybe kind of easy wins or a good starting place for us to start on this system dashboard. So that's our kind of objective for the conversation today, but really want to get your thoughts after seeing kind of a little more information on each of the indicators and the sources. So again, just the overall goal of the dashboard or for this work group in relation to the dashboard was to finalize the data dashboard and an implementation plan that really supports, again, the system improvement. These are really system level indicators, and the reduction of health disparities. And again, that's why that disaggregation is so important as much as we can across the sources. So maybe I can do a quick check-in to see if the group feels ready to kind of launch into some of these questions in that discussion, or if it would be helpful to kind of go through a summary of the indicators and the information that was sent on that spreadsheet. Anybody jump in with any thoughts on that, and then I'll move forward.
I would think that a review of the indicators would be warranted.
Okay, I'll go ahead and do that. That sounds great. So, and if anyone did not receive the spreadsheet, please let me know and I'll be sure that that I send it out, send it to you. So, again, the dashboard was, per prior conversations, broken into a framework that included prevalence and need, as well as, workforce, quality, cost, and population outcomes and throughput. So we'll just, this is a really just basic summary of kind of what the sources have available. And maybe just can be kind of a quick reminder of the indicators before we launch into the discussion. So around prevalence and need, we had identified a few indicators coming from the YRBS. And, kind of the pros of that is that it's very much publicly available, as well as, for disaggregating, most demographic variables are available. The downside is that it's only available every 2 years, and it is a small sample, although recent legislation did mandate that schools participate, so it should be a bit more robust in the future. We also, and just a note that for the trauma screen, there's some possible alternate sources, and there's kind of pros and cons for the various sources that are available. There was an interest by the group in looking at the rate of identified developmental disability, and a few different public available indicators for that. Most of these indicators do not have publicly available demographic variables, so we need to kind of get some agreements in place with the agencies who collect that data. When we look at throughput, a few indicators here, mostly from the bed report that the Hospital Association collects. This is not publicly available data, so again, would be something that we'd need to explore with CHA. And we don't, beyond ED and inpatient, we don't have a lot of data that can be, or that is collected that supports throughput. So that's probably something to more explore as a priority for the future. When we look at workforce and quality, we had selected a few indicators here in terms of the ratio of available behavioral health staff or clinicians, as well as kind of some workforce quality or training pieces, specifically around training on evidence-based treatments and the organization's adoption of class standards. Sorry. Cost, the out-of-pocket cost is something that we could potentially request through the all-payer claims database. We had also, the work group had been interested in that ratio of actual cost to reimbursement, and I think that's something that we are still would need to identify a source of data for. And then finally, looking at population outcomes, we had, as a group, identified the rate of suicide attempt, the rate of inpatient utilization, and the number of ED visits, rate of ED visits for behavioral health needs. And there are a few alternate sources for these as well, I would say. So with that, with that, I think I'll go back, sorry, to the list of questions that we had to kind of just guide the discussion. And if anyone would like me to jump back to any of those other slides with specific indicators, just let me know. So I think, first we just want to do a check-in again, if these are still kind of the right indicators, if that information brings up issues where a different indicator would be more critical, or also if a different data source is preferable that's not identified currently. So we'll start with that question, if there were any thoughts around the indicators, whether this is still the right list.
Elise, this is Tim. I'm wondering if you could maybe copy these and drop them in the chat box, and then maybe
Oh, sure,
we
and
can
then bring the,
look at
yeah.
it. Yeah, we can look at each other.
Oops, sorry. Yes, I think I can hear.
So for me, I thought, you know, reviewing those, I know I had a chance to look at them before the meeting, but for me, those still seem like the right indicators. I think the wish list issue is the question I think we were all struggling with, and then what's doable. So I just kind of the recap of the early part of this meeting was when we're trying to keep this project moving, trying to both demonstrate and utilize the P20 win infrastructure for children's behavioral health and keep the project moving. And so trying to figure out what would be the indicators that would be easily accessible to the overall project and make sure we move forward. So for me, that was a great list and a good review.
Yeah, I agree, Tim. I think that the list is a good list. The biggest question that I had was really about the youth risk behavior survey, because it did say with the data source that, you know, it was an anonymous survey of high school students across a random sample of 50 schools. So, but that recent legislation would require the school participation. So it's a matter of kind of what that legislation is going to mandate, so that you're not just looking at 50 schools, you're looking at all schools. So.
Yeah, that's it. And I don't believe that it will mandate all, if somebody knows otherwise, but I
Yeah.
believe it's just mandating participation by the schools that are requested. I think right now, the response from schools is not fully from that full list that's requested.
Yeah, so I'm a little bit familiar with it. It's really a DPH activity that they do. And they, in order to utilize the results, they have to meet the minimum standard per population in order to use the results nationwide. So what's great about it is, one, it's been so long standing, and two, it's great benchmark outside of the state, as well as a year from one year to the next on this. But I think where DPH has been at the last two times they administered is they've been right on the bubble about whether they have enough schools surveyed in order to be achieve the threshold as a minimum standard for good random selection among the schools. So DPH selects their schools, and then they are, quote, invited to participate, but there's no mandate for them to participate until this legislation. So I think DPH will meet the threshold from this point out, and that the data would be strong data based on the standards for that administration.
Can I ask on that survey? I didn't realize that it was actually national in nature. Because like I think they had like rates of alcohol use or rates of I forget the exact parameters right now, but I was also wondering how many followed up seeking services, and is that a question that's asked on that survey? And then if it's supposed to be consistent across states, can we modify it?
So every state, my understanding, and Cecilia, I'm forgetting her name right now, is the lead at DPH. Last name's escaping me, but so my understanding is the core of that is set nationwide, and that every state has an opportunity to add a handful of questions. I think DPH struggles with that because there's quite a bit of competition for adding questions and what they would be, and then how that data would be used and why they would add them. So I think it's been set pretty steadily for the last few years. That's the information that very much informs a lot of the suicidal ideation and prevalence rates among kids. It is self-report, it is anonymous, and it is randomized across the state. So those are all parts of that. But specifically to your question, I don't know about those concrete follow-up questions. I don't think it lends itself to that. So I'm not sure if that is part of it.
Yeah, and it looks like it's done every 2 years. So you'd be looking at the same data for a couple of years in that dashboard. It just stuck out to me because there's a lot of the a lot of the indicators are coming specifically from that survey.
Yes, it is a very rich and robust data set, however, and again, there's multiple years. So again, you can see a period of time. You can you compare this data over periods of time. So there's a lot of utility to it. I do think DPH uses it for a variety of reporting mechanisms also.
Yeah, I guess one other benefit is we can look at Connecticut in comparison, somewhat in comparison to other states as well, or national. But definitely those drawbacks of the timeline and challenges with the sample at times are certainly for consideration. Any other thoughts about the indicators and the sources? And I'm just going on to that next question. If there were additional data sources that we don't have on there on this list right now that would be good to include, or good alternates.
This is my first time here, but I just have a question, and maybe something people have talked about before, but on the access tab, there's the ED awaiting inpatient and the inpatient availability. Is there data on like inpatient awaiting community-based services? Is that something that's already been talked about?
I think that's a really important piece that yes, I think the work group has definitely had interest in. To my knowledge, we don't have a mechanism or a data source for that systematically.
The challenge with that, so there's a little bit of information we may be able to get on kids who are stuck in an ED or who are stuck in an inpatient who are waiting for community-based services. So there may be a little bit of information there. The challenge with, essentially the wait list question is what often people want, is that each service type and each organization is often different around the way they may track quote unquote wait lists. Our experience at DCF with providers is sometimes they're not so comfortable keeping a real formal list just because of potentially, like, are they engaged or not engaged under the organization yet or not. And then there are a number of services that are not supposed to carry wait lists. So there's not supposed to be a wait list. So there's a variety. So in PI, for example, there is a data element, but you don't really open up an episode of care under PI until you're actually in treatment. So collecting information on Tim Marshall waiting is not going to happen until Tim Marshall's in. So it's complicated, and it's not always an easy measure to get at.
And there's also the phenomenon that, a youth is referred to multiple program types at the same time in order to kind of fill a slot, so that with the hope that one of them will become available. So you can have, John Jones, who's referred to 3 or 4 different program types from the hospital because they're hoping that it'll increase the chances they'll get picked up quicker. So that inflates the numbers.
Did we ever have any conversation about juvenile justice involved youth? Or does it make any sense to add them and add CSSD as a data source? I see you smiling, Tim.
Yeah, I think part of it. So I think this is where the activities of this group sometimes, because it's not meeting so frequently, may be challenging. Because so I think one of the steps we're at as a group, at least you can correct me if I'm wrong, and the folks from OPM, is that the more data sources you add from the more state agencies, the more data sharing agreements you need to get, and the bigger the project gets, getting off the starting line to get going becomes more and more difficult. So I think we were trying to get down to, can we slim down what our thinking is? Can we slim down kind of the low hanging fruit, that is to go after those data sources that we know and maybe develop some data sharing agreements that might be easier than others. And so, for example, are the other State Department partners or judicial partners, are they in P20 Win already or not, et cetera, et cetera. So there was a whole bunch of factors that contributed to kind of the thinking on that. But Elise, correct me if I'm wrong, I think we did have a number of indicators that originally were coming from judicial branch CSSD, and then I think we were trying to narrow it down.
That's definitely correct for that P20 Win component. I think for the dashboard, likewise, I think there's an opportunity to both identify available data and kind of get a system dashboard launched, but we could also be, thinking about a data development agenda or priorities, and certainly keep that list going as well.
Yes,
Sorry, go ahead, Tim.
No, I'm sorry. I'm kind of combining the two projects again. Sorry, I do that frequently. So this is the dashboard, and then there's the P20 Win project. But sorry.
But yeah, still a challenge in terms of getting that CSSD data, I think, even for the dashboard. But I think that doesn't mean that we just ignore an important indicator too. So I think Beresford, if there's a specific piece that we, is important to include, we can keep that list going of what to look for in the future as well, I think. Any other additional data sources?
Well, Beresford, do you have a follow-up? Do you have a recommendation regarding a data source that you might want to see in there for juvenile justice contact? Or
Well, I'm just thinking because when we talk about data coming from schools, I think that there might be a cross-reference or relation there with kids and how they're being educated, but also how they're being treated for mental health situations. Knowing and acknowledging that it may be a small population, I think it's an important population because they may be some of the harder kids to place in a community-based support. Just like kids get stuck in the ED, kids get stuck in juvenile detention also. So there's parallels right there.
Yeah, I agree with you, Beresford. I think we need to add, at least one data metric related to our youth and, who are in juvenile justice, involved with juvenile justice. I'm not sure what the data source would be.
We can definitely explore that. It's obviously a really critical part of the population.
yeah, maybe that because there's a fairly decent, robust data set that comes, and there's the CSSD driven, and there's the court reported data. I think that also still goes through CSSD, but and I think there's I think there's a mini dashboard, if you will, that might already exist that is used and generated somewhat routinely. So it may be that maybe exploring that to see might come off of that for this group.
I'm wondering if a quick call over to somebody at JJPOC might be a way to figure out if they've got some kind of dashboard going already that we could just lift a little bit of data from and share with our group.
Yep, that sounds great. I'll follow up.
Just I can try and put I try and find a link and put it in the chat too, but there is a dashboard through JJPOC, which is Juvenile Justice Policy Oversight Committee, that's looking at juvenile justice outcomes and racial disparities in that. So we have the OPM is working with CSSD on that. I don't have the metrics like readily at hand, but I think for the more general point, adding something in that people want to see is a good idea to put it on the table. And then if the answer is no, this is not accessible, then at least but I wouldn't keep things off the table because of the perception that they're inaccessible for Tim's general point, this is, I think, a reason for the goals that the group had put in place earlier, is that you've got more than just this one boat kind of rowing in the same direction. So there's other separate projects that are looking at, similar populations, same types of metrics. And so I think there's a more general push to get some of these things more readily accessible for this community, both for the dashboard and for the ability to integrate data across agencies. So hopefully that won't be too far out. It's not an unrealistic thing to ask for. I'll try and find the JJPOC link kind of while we're talking. I'll put it in the chat.
Thank you, Scott.
So I know we want to get into the P20 win piece as well, but I'll just ask two more questions. Just if there were any corrections that you had identified when you went through, you could either raise them now or just send them to me later either. And then are there indicators that jump out as a good starting place for us if we're, thinking about launching this dashboard and as a next step, doing a mock dashboard, are there either components of the framework or indicators across the framework that jump out as a good place for us to start with that?
Actually, if I could ask a quick question on data sources, the throughput one, the bed report that is not yet publicly available. I'm wondering if it makes sense to look, can you look back historically using the APCD data? So it wouldn't be like, time, at the current situation as a bed report is, but maybe you could look back.
Yes, yeah, I think you're right, Manisha. Yeah, that's a good point.
So we can add the historical component to it.
Yeah, thank you.
Yeah, so my opinion just related to that is to pick, the indicators where you have access to the data. So kind of those low-hanging fruit, the ones that are the easiest to pull, because I think they're all great indicators, and it will help us to have the experience around kind of putting them together and what it's showing us a bit. So that would be my recommendation, is to start with the ones that are the easiest data sources where you don't need the data sharing agreement, and because I think they're all great.
Do we have a list of those in which we need the data sharing agreement compared to those where we don't need the data sharing agreement? I think that'll be telling also.
Yeah, I think that it is available. And then I guess the nuance is that a lot of data is publicly available in aggregate, but if we're looking, if we want to really get into equity, which is obviously a primary goal for us, is we'll need the data disaggregated, and a lot of the indicators we would need some sort of agreement or request to do that. But I think to both your points, we can definitely start with what's publicly available, and then be able to be working on those other discussions simultaneously.
Thank you.
Anything else around the dashboard before we move on to the P20 Win project? All right, thank you all so much for the input, and also please reach out by email in the meantime if you have additional thoughts or corrections, additions, anything. I'm going to bring up the PowerPoint again to go into the P20 Win piece. So just some additional context. I know last time we met, we discussed a pretty robust or complex proposal for a project to work with P20 Win, looking at kind of a demonstration of integrating data to really identify opportunities to improve the system using cross-agency data for system improvement for children's behavioral health. and that was I think that really helped us kind of identify what opportunities there were for looking at that information. And then as we, really dug into it a little further, really ended up kind of identifying some challenges with some components of that project that would really place the timeline at, pretty far out. And we really wanted to keep that on the table as something to, potentially return to in the future. But in the meantime, identify something where we could really demonstrate the integration of data and identify some opportunities for improving the system in a more short-term time frame. And so to do that, and again, we're looking at data from agencies that are already a part of T20WIN. We really narrowed kind of the time frame, but primarily the number of agencies that would be requested to supply data for this project. And one of the ideas that was put forth as something that could really potentially inform us as a system was looking at children being screened in a primary care setting for receiving a behavioral health screening in a primary care setting, looking at are there potentially disparities in that rate of screening. Then looking at, of those children who do screen positive, are they subsequently receiving services? And using both the DSS Medicaid data as well as possibly PI data to look at what services are received. And then again, looking at were there disparities in that in access or utilization. With the intention that we identify opportunities for improving coordination between primary care and behavioral health, and also improving equity. So I want to open it up to the group, and I can put some of these questions in the chat. But we really want to bring this to the work group of just to get your overall kind of feedback and thought on seeing that proposed project, but also, if you do feel like this is a good direction to go in, are there considerations? There's a kind of a few questions that we've specifically we're hoping to get some feedback on. One is just, the recent legislation that does mandate the 2 screenings annually, or the annual screenings. Is there anything to consider in relation to that? And then especially, which well child visits would we want to look at? Obviously, there are a lot of ages where a behavioral health screening is recommended. And so how do we want to narrow that? And then how do we want to bring in either DCF PI data or potentially a different source of data to integrate and look at how the system can be improved from primary care to linking to other services. So I'll stop sharing, but if it's better to bring it back up, just let me know. So I guess just initial reactions, is this something that you think would be beneficial to the system to look at as a project and inform us moving forward?
I just see one issue with the data that you're pulling, because you're looking at the DSS Medicaid data, right? Your PI data is going to include all populations, right? So even though DCF funded providers, get funding, some funding from DCF, it's the whole population. So you're really not comparing apples to apples when you look at it. I don't think there's any way to cross-reference which kids, were targeted in a well child visit versus which kids actually got the services. So I guess just a cautionary note related to that. You're not looking at the same kids between the 2 data sets.
Yeah, I think so. The idea would be that we would match the Medicaid data with the PI data, but as you said, that would really limit the children in PI that we would be looking at. We wouldn't be looking at the children with private insurance or otherwise, which I think is an important piece to keep in mind.
So you would essentially look at which kids in the PI data you would look at. Because
yeah.
you buy based on what the reported insurance was.
Well, actually, I think they would match the children pulled through the DSS data if there was a match with the children in PI. And I believe Manisha or Scott, that opportunity we think will exist through the P21 process.
Just on the technical side, it is what you would do is link the individuals across the two different data sets using whatever identifiers, their name, date of birth, some other identifiers. So I think Kathy had the same question earlier. That's the kind of thing that necessitates a data sharing agreement. If it's aggregate data or something, that's usually not always, but a non-issue. So on just the mechanics of it, you would be able to link the identified information across the data sets to look at the same cohort from data set A and data set B and data set C and so on. I think to your broader question, is that what you want to do? Because it is only a subset of the overall population. That's the question, I think, for like the group to debate. Is this something that would be useful? How would this help? The mechanics of it, I think, we could sort of find a way to make that work, but it's really, would that be valuable to see just the Medicaid recipients overlap with the PI database, for example?
Yeah, because I believe in PI, you just need a name and a date of birth. There's no other required identifiers in that data set, but I could be wrong. So as long as you can match through name and date of birth, those would be the only common identifiers, I believe.
It wouldn't be 100%, but you get like close enough for a large enough population that you should be okay.
Okay.
We've done a probabilistic matching between both the PI and the Medicaid data before. There are some discrepancies you have to have decision rules about, but I think it's an interesting question. I think there's just two things that you would probably have to contextualize with that question. One is about provider billing practices. I think that other providers on the call could probably speak to it, is that screenings are not the highest reimbursable service. And so what you may see as the proportion that are actually receiving services, you have to take that into consideration, is that may not be the true number of that are receiving services, screenings, I should say. And the second contextual point that first just came up was thinking about if we're wanting to look at health disparities by demographics for well child screening, is that we're looking at those that have utilized well child screenings. We know that there are already baked in disparities in utilization by demographics, even for well child screenings as well. So we know that there exist disparities before that. We're going to be measuring after the fact. I think that you have to contextualize that because we know there are things that are already disparate even before the well child screening. So two major things just to consider and contextualize.
Thank you, Chris. That's really important for us to keep in mind. Thank you.
But I don't necessarily think that those issues should prevent us from doing that, right?
Right. Yeah, I think
we just have to, in our assessment of it, we just have to keep those in mind, right?
Right, exactly.
Yeah.
That's the contextual piece of just saying, here's the data, this is what we do have, this is what we can say. There are other factors that we should take into consideration as well.
To the reverse of Chris's point, I think, so would it be interesting to also look at this kids that are receiving services in PI, but never received a screening, or maybe I don't even know, maybe they didn't get a well child visit.
It could be what Chris is saying, that the provider did not bill for that screening because of limitations in their billing systems, or kind of the effort to do that billing wasn't worth the amount that they're getting paid to do it.
Exactly.
But could it be that they never did it? So maybe not all children make it into the system through, like how many of them, I guess, make it into the system through those screenings and well child visits?
I think all that information is important. You know, if it's set up and it's supposed to work a particular way, and it's not, but kids are still getting through, I think that's just as important to know as any other information. You know, I had a saying probably 20 years ago. It's a squeaky wheel that gets the oil, but if it continues to squeak, it gets replaced. Rather than us looking deep into the whole apparatus to figure out why that wheel continues to squeak. Does that make sense? Thanks, Jeff.
I think many of us may steal that verse for.
I'm going to copyright it soon, so I'm going to steal it, get on it.
Well, to that point, we would want to know that all children get screened, all children who get a pediatric visit. So first there's how many children get a pediatric regular visit, but there's all children who get a pediatric visit get screened at some regularity. And then if they screen positive, they get connected to, I mean, that's ultimately what we want to know. So we would know what portion of children get screened by knowing to some degree, except if it doesn't get billed, we would know that by the number who have Medicaid, who have a well child visit, then what percentage of those got a screening.
But how does the new legislation play into that? So I apologize, I'm a researcher. I'm not familiar with this behavioral health system as much, but like the new legislation requires all children to be screened at this point going forward, right? I think. So then I guess we want to hopefully at the end of this research project have something that's like data results that are actionable, or at least I pose that to the group in your consideration of the project.
So I have the language from that legislation, but I'm not sure. I guess for the group, if people think that there would be changes, I think probably changes at the ED level from the required new screening, but do folks think that there would be changes within primary care in terms of screening? Anyone's familiar kind of with discussions around that, more familiar with me than me?
Can you go back to the diagram that you were showing us?
Yeah, absolutely. Here, this is a cleaner version. So I think, Manisha, is it fair to say the question revolves around, is this proportion of children receiving a screening inherently going to change due to the new legislation? Is that essentially what the question is?
Yes.
Okay.
I'm wondering if it's going to be up to 100% or should be. Maybe that's something we take back and research.
Yeah, I'd be happy to follow up. I don't know if any, so my sense of it is that, but I really would invite anybody to correct me or jump in, is that, you know, these are already recommended screenings. And so if, I'm not sure whether or not at the primary care level we'll see a big difference, but I could absolutely be wrong on that. So if there are, other thoughts, please correct me. But it's, Manisha, definitely, follow up and see what the thinking is at this point. All right, so with that question, definitely for continued follow-up, were there other questions, concerns, any thoughts around, if we move this project forward, which well child visits would be important to, more important than others to look at? If adult, are we especially interested in screenings taking place during adolescence versus earlier in childhood? Any thoughts around that?
I think it'd be important to identify where they're available. And if it kind of falls off towards adolescence, towards transitioning to adulthood, especially in those transition areas and those transition times. If it's school environment, then we're talking about elementary to middle school, what's happening there, and closer to where the abundance of incidents and circumstances are happening around mental health and anything else that we're trying to get the answers in all around.
So potentially some kind of descriptives around what are we seeing the screenings occur more regularly at specific well child visits at specific ages that children are receiving care.
Yeah, especially around transition. Transition is usually a time of what I say, and I don't know how much you like this, Jeff. Change in transition usually is accompanied by inconvenience or harm. And in those areas or at those times, I think the onus is on us to make sure that we minimize that harm or inconvenience and not marginalize it. I think sometimes we do marginalize it, or it just goes over our head. Sometimes when kids change schools, change environments, move, something like that happens in their life.
Yeah, I think you would need to look at the data that you're getting and determine if there's, some clustering, because I believe that kids still in certain grades need to get certain physicals in order to be in school. And so you may find that that's where kind of the ages where they cluster around. So I think you probably have to just see what you have for data that indicates the well child visit. And I would have no clue as to kind of how that's coded, obviously. If they're doing a visit, a medical visit, and then a well child visit, and then in addition, they bill for the depression or suicide risk screening. So I believe that now they can do that. But that would be in the future and probably not looking at history so much.
Thank you, Kathy. That's helpful. I think, Elizabeth, I think you had your hand raised, and then I'm going to let us wrap up.
I think that we should go, and I don't remember, I think we should go with what the American Academy of Pediatrics would recommend, as we would be recommending that a behavioral health screening happen at every well child visit. And, now early on, they're more frequent and they become less frequent further on. But at every well child visit, we would want there to be a screening, because the idea is to detect difficulties, the sooner the better. So I think we would want to say that our recommendation is that a screening happen at every well child visit. Then I think we look at, any trends along the lines of periods of transition may be where we see increases in positive screens, but I think our frequency should match what the American Academy, at least what the American Academy of Pediatrics recommends, both for frequency of well child visits, but also for frequency of screening.
Great. Yeah. Yeah, we could kind of apply the periodicity schedule and see what we're actually seeing in terms of screenings. I think that in itself could be helpful for us to know.
I think that's an excellent baseline, Elizabeth. I think we should also pay attention to some of the efforts around diversity, inclusion, and equity to be able to compare whether there are issues around race and ethnicity or disparities that might be indicators that we might need to change some of that. You know, I think that also makes sense, but I think that's an excellent baseline to start off with.
Well, and part of the fundamental question there is, are our children having well child visits at the frequency that's recommended? Because that's where there are some disparities that we want to be, or where there's potential for disparity we'd want to look at. So the one is getting the well child visit as the opportunity to do the behavioral health screening in addition to the other physical health parameters. And in Connecticut, I think we've rated better with how many children are connected to well child visits than some other places, but that's something we want to pay attention to.
Absolutely.
I think another question for the group is how far back we want to do this analysis. You know, I'll just throw out like 5 years, 10 years. Of course, we'll have to like work with the agencies to see what's possible, but another consideration.
So I'm thinking maybe we can, we will be scheduling another meeting and I just want to respect everyone's time. So we'll be scheduling another meeting, I guess, for sometime in December, but we'll think through what really, you know, makes sense given holiday schedules and everything, and bring back a more fleshed out component with all of these, you know, great pieces of feedback included, and then identify some additional opportunities for next steps there. With that, I'm going to pass it over to Manisha for next steps or wrap up and Beresford to adjourn.
Sure. Yeah, no, thank you, Elise. So again, thank you everybody for your time, your expertise. Again, myself and Ashley are going to be working closely with Elise to move this work forward. Very excited. We rely on your knowledge to really make sure we're heading in the right direction. So you know, I think excited to hear that low-hanging fruit that jives with what we were thinking too. And I think we developed a lot of interesting additional questions that this data research project, the P21 project, can generate. So thank you, everyone. I'll hand it over to Beresford.
Yes, so I have the easy parts of this. So I do the introductions and I do the adjournment. One thing I do want to say though, and I do, Manisha, appreciate the identifying, going after the low-hanging fruit. But I think low-hanging fruit is only low-hanging compared to who's reaching for it. So I think that's something also we need to take into consideration. And like Elise said, our next meeting date is going to be sometime in December, unless otherwise discussed or decided. But we should get that information out soon enough so everyone could respond back with their availability. Everyone have a good rest of the day, and enjoy yourselves and be safe, please. Thank you.
Bye, folks.
Care.